Good morning. Today we will discuss new 2025 guidelines regarding differentiated cancers, when to go for de-escalation, active surveillance to avoid over-treatment versus correct follow-up with especially in tumors aggressively subtypes, for example, tall cell or columnar or hopnial, which are aggressively variants, need escalation for to minimize recurrence up to 30-50%. For example, hopnial variant highly aggressively due to high vascular lymphatic invasion, distant metastasis, especially in lungs and bones, and also tall cell variant which has extra thyroidal extension in 60-80%, node metastasis in 70%, and also 70-80% higher recurrence than classical BTC. And that's why in some subtypes we must, or in some patients we must do molecular testing to guide next assessment, and also according to oncocytic type, we know that oncocytic type has in Russian studies approved that it is correlated with anaplastic thyroid cancer due to they are rarely differentiated to anaplastic via TP53 mutations, especially post radiation and or in Hashimoto, and also oncocytic subtype. They are in 30% they are radioiodine avidity, and also we don't to forget rare syndromes like Deschers syndrome or Cowden syndrome and Carney complex or Werner syndrome and Cribbiform malarial thyroid carcinoma. These types we must be considered in any thyroid patients. So going for next that we know that it depends on which risk it is, low risk or intermediate risk, or for example here when we're dealing with the low risk, we're dealing with the non-invasive follicular thyroid variant of prostate cancer and follicular tumor of uncertain malignant potential, and highlighting trabecular tumor. This variant are low risk, but malignant. For example, if the pathologist give you only follicular diagnosed with only follicular thyroid carcinoma, it is dangerous. Just you know, that's very important to know which subtype, because if you know which subtype and the clear diagnosis is done by pathologist, you can follow the patient correctly and to do the right option for treatment. And when we talking about subtypes of papillary thyroid cancers, there are many subtypes. We must consider that tall cell columnar hopnial are very aggressive subtypes. So that's why here going for recommendation number 1, non-invasive follicular thyroid variant of papillary thyroid cancer, and also uncertain malignant potential and highlighting trabecular tumor are diagnosed pathologically and have very low malignant potential, lower than the lowest risk differentiated cancers, and further treatment with completion thyroidectomy or lymphoadenectomy and or radioiodine is not advised routinely. The optimal approach to postoperative monitoring of this tumor is uncertain. And we know that this we not forget Especially these findings must face any endocrinologist. This is real syndromes, but we face in clinical practice. For example, Cowden BTN syndrome. It is also, associated with papillary or follicular thyroid carcinoma and clonic polyps are characterized, and there are an elevated risk of breast, endometrial, and renal cell carcinoma, and in some for example, cardiac complex. Also, we saw coexistence of acromegalia or Cushing syndrome even. So we must to be very cautious in this subtypes and in these syndromes. Here is some findings in different syndromes, and also recommendation number 4. Should family members of patients with familiary non-medullary thyroid cancer be screened for thyroid cancers? Individuals with family history of family non-thyroidal medullary cancer should have a careful history and directed neck examination. So ultrasound may be considered in first-degree family members of individuals who meet criteria for clinical diagnosis of FNMTC due to the presence of 3 or more individuals, and also even may also consider in families who only 2 affected individuals showing other concerning features like young egg or limited family structures. The egg for initial for such screening requires further study and should be carefully weighted against the risk of over-treatment. And does surgical experience influence complication rate for thyroidectomy? Due to lower complication rates and improved outcomes, and on a freak associated with high volume thyroid surgeons who do more than 25 or 50 thyroidectomies per year. By the way, in some centers even more than 100 they are doing operations. So very important to know high qualified high volume surgeon who do more operations, more experience, but sometimes more operations, more mistakes. So that's why some patients they are doing only active surveillance. Some patients must to do more aggressive escalations, especially in aggressive subtypes. And also here, when we should preoperative cross-sectional or 18 fluor deoxyglucose PET scan. Here, when we do routine preoperative 18 fluor deoxyglucose is not recommended prior to surgery. This is strong recommendation. And performing preoperative cross-sectional imaging of the chest, abdominal, and pelvis is search for distance as is recommended in situations when result will influence extent of surgery. Because should we do thyroglobulin levels before surgery? No, but because it is not recommended, and in some cases may be helpful, in some cases only. Here, should preoperative somatic genome testing be performed to inform the extent of surgery? Genomic evaluation of confirmed differentiated cancer prior to surgery is not recommended routinely. However, if the genomic profile is known or performed, the presence or absence of specific combination of abnormalities may be considered in context of clinical, radiographical, and cytopathological data to inform extent of surgery. This is conditional recommendation. Here, are the patient in home active surveillance and percutaneous ablation are appropriate management options. Active surveillance may be offered as an appropriate management option for some patients with T1 N0M0 BTC, and sharing clinical decision making between patient and clinical team regarding risk and benefits of this approach is essential. Also, ultrasound guided percutaneous ablation may be considered as an alternative to active surveillance or resection for T1 N0 BTC in selected patients. That's why it is very essential to share with clinical decision with the patients and medical team. What is the optimal approach for patients undergoing active surveillance? Just only neck ultrasound should be used to monitor the disease progression. They are doing usually every 6 months or for 2 years, but it depends in the prior findings, and also here going for are there clear indication for when patient undergoing active surveillance should be previous resection? If this volume increased by growth more than 3 millimeter, or finding distant metastasis or evidence of extrathyroidal extension or posterior growth, there is here, or in some patients they have an anxiety or an inability to follow up, so must be this patient has perseverance for surgery, and here going for some, in some cases we have tumor that not affect the capsule and just only less than 1 centimeter for observation, because it is far away from capsule and from nerve or from important structures. And going to this slide, look, sometimes it is when the tumor located near laryngeal nerve, but between them and the nerve is a layer of healthy tissue we can observe, and if the acute angle between the trachea and the tumor, meaning the risk of growth is low. So in this case we can observe even in minimally invasive, and also going to in some cases when we see that the tumor invade adjacent tissue, either fatty tissue or neck muscles, minimal invasion or rare are located in the projection of the carotid artery, so for operation. But in some Korean and Japanese, they are think sometimes maybe they said that it's possible to observe, but different surgeons will be have different options, because some cases it depends also on genetic mutations, and also here early efficacy of radiofrequency ablation for multifocal T1 N0M0 papillary carcinoma approved that the size when the follow up in months will increase in 20, even in 50%, even in more. Here, what is the optimal operative approach for differentiated cancer? It depends due to size, without, for example, if it's less than 2 centimeters without gross extrathyroidal extension and without metastasis, here Initial surgical procedure should be a thyroid lobectomy unless there are bilateral cancers or there are indication to remove the contralateral lobe. For example, patients with unilateral thyroid cancer between 2 and 4 centimeter, thyroid lobectomy may be preferred as initial surgical treatment due to significantly lower risk and side effects. However, if the patient and treatment team may be adopt total thyroidectomy to enable radio iodine therapy administration and also to enhance follow-up based on disease features, suspicious contralateral nodularity and patient's preference, and even in the findings during interoperatively, so that surgeon will be changing the volume of abrasion. And some patients who has more than 4 cm cancers of any size with gross extrathyroid extension and clinically apparent metastasis disease to lymph node and distant size. The initial surgical procedure is total thyroidectomy with the gross removal of all primary tumor and node dissection unless there are contraindications. And this is strong recommendation. Here, going to what is the surgical approach to thyroglosal duct carcinoma. Here, the initial surgical therapy for thyroid carcinoma arising with thyroglosal duct should include complete tumor or cyst excision along with the central portion of the hyoid bone, and also here sometimes thyroidectomy may be considered with significant suspicious thyroid nodularity to ensure complete section of possible multicentral disease or for large tumors, particularly in the older age, to facilitate radioiodine and or enhance follow-up. And here, for example, usually the tumor located here usually, and if it is affected, for example, right or left lobe, it can be removed with the affected lobe. And we know that they usually doing operation in this place. Also, delphine nodes will be removed. Also here going to see some words about the central the central zone located between the inner edge of musculus sternocleidomastoideus studios and also the add 7 zone, which related to the mediastinal lymph node right here, and also this is a continuation of the central tissue of the neck in the mediastinum. Very important to know that 70% of papillary thyroid cancers, or sometimes 50 or 40 or even 70%, located in central zone. And regarding to lateral zone 2, 3, 4, 5. Located under the sternocleidomastoideus, and 5 is lateral to this muscle, sternocleidomastoideus, and also we are here dealing with the lateral zone of the neck. Here the zone here, zone 1, it is very rare to metastasize to this site. Going, as we said, that very rare to find metastasis in the zone 1, but you will find thyroid metastasis in lymphs in central lymph node zone, approximately 40 up to 50, even sometimes 70% of metastasis, and in follicular thyroid cancers and also in BTC T1, T2, prophylactic central compartment lymph node resection should not be performed. Only may be considered in patients with BTC and clinically uninvolved lymph nodes who have advanced primary tumors T3 or T4, or for whom the information will be used to plan further steps in therapy, but this approach should be weighted against the risk as they evolve during thyroidectomy. And also, when we're talking about the central tissue of the neck, it is located deeper. It is located deeper than the layer of veins and that originate from lower pole of the thyroid. Here is the parathyroid gland, here veins, and thymus located here, and between the veins and inferior thyroid gland, and so the layer, the beneath this layer fatty tissue where the central lymph node are located. Here the central node located here. So in literal view here we say that this is the thyroid, this is inferior thyroid artery, and this is parathyroid gland, and this is anterior mediastinum, this is posterior mediastinum. That's why central lymph node located here. That's why sometimes it is very dangerous to do central lymph node dissection due to location in location. And also here, when they compared in Russia hypoparathyroidism in after total thyroidectomy and after lobectomy, they found this is the difference between hypoparathyroidism after lobectomy and thyroidectomy, and but also here they found that there is no persistent hypoparathyroidism, approximately 0% in all types of thyroidectomy. And also here, when in Russia they studied that the metastasis to lymph node after thyroidectomy and central lymph node dissection, they found that in thyroid cancer they have approximately 60% they have metastasis, and when they do hemothyroidectomy plus central lymph node dissection, they found 43% have metastasis from thyroid cancers. I'm going to next slide. What is the best approach for therapeutic central and other compartment node resections? Because it is in patients who clinically involve central nodes should combine thyroidectomy to clear disease from the central neck. This is a strong recommendation. And therapeutic central lymph node dissection with dissection of the epicellular central compartment lymph node is recommended to combine lateral compartment neck dissection and thyroidectomy for patients who clinically involve lateral neck lymph nodes. This is conditional recommendation. And also in patients who has obvious metastatic lateral compartment cervical lymphadenopathy, the therapeutic lateral compartment lymph node dissection, typically including level 2A and 3, 4, and 5B, should be performed as a part of initial surgical therapy for these patients. And should the patient undergo voice or laryngeal examination? Yes, of course. Should undergo voice assessment as a part of their preoperative physical examination. That is the reasons in which we should perform all the voice or laryngeal examination prior to surgery. And how should the recurrent laryngeal nerve be assessed intraoperatively? Visual identification of recurrent laryngeal nerve should be performed. Thyroidectomy and paratracheal node dissection to preserve nerve integrity and function. And intraoperatively, neurophysical monitoring of the recurrent laryngeal nerve may be performed during thyroidectomy for malignancy in the effort to reduce the risk of laryngeal nerve recurrent laryngeal nerve injury, particularly during the total or reoperative thyroidectomy. And also sometimes the doing intraoperative identification and neurophysical monitoring of external branch of the superior laryngeal nerve may be performed during thyroidectomy for malignancy in the effort to improve accurate nerve identification and improve voice outcomes. And here after the total thyroidectomy and central lymph node dissection, or after unilateral operation that followed prior contralateral thyroid resection, parathyroid hormone directed calcium and vitamin D supplementation should be provided to reduce rates of hypocalcemia and shorten hospital stays compared with observation with serial calcium measurement alone. This is strong recommendation. Should drainage of the thyroidectomy bed be performed? No, because it can be associated with the increased length of stay, may increase infections, and does not reduce the incidence of hematoma. Here, assessment of or should the surgeon manage post-operative voice changes and symptoms after surgery? Yes, if the voice is abnormal, and if it is now in that injury from the surgery, also timely referral to speech language pathologist or physician specializing in voice is recommended. What are the basis principles of histopathological evaluation of thyroidectomy samples? Here, in presence of vascular invasion or invaded vessel or number of lymph node examined and involved with tumor size of the largest metastasis focused to the lymph nodes, or presence or absence or extranodal extension of the metastatic tumors, the staging and status of resection margins. That's why they should include additional information for risk assessment. And some histopathological subtypes of differentiated cancers associated with unfavorable or for example tall cell or glomerular cell, which we see Hopnil and subtypes, they are very aggressive, so that's why. And also here widely invasive follicular thyroid cancer or oncocytic thyroid carcinoma and high grade follicular cell derived anaplastic thyroid cancer, or this is favorable for low risk types, and also should be identified during the histopathological examination and reported. In some cases, which are associated with familial syndromes, cribriform molar carcinoma can be associated with familial adenomatous polyps. That's why the refers to gastroenterologist for evaluations and treatment, and also associated with follicular thyroid carcinoma or BTC. These should identified during histopathological examination and reported. Here the staging, if the patient less than 55 years, stage 1 and stage 2, and if it's more than it's more than 55 years, the stage 1, 2, 3, 4. So there is we know that estimated risk of structural recurrence is very important. The dealing with low risk and now intermediate risk is divided into categories: low, intermediate, and intermediate high. So this is very important to have this scheme in with every endocrinologist, because it's very important to know which category and which type of how to follow and which is the correct assessment and follow up. And when we going to should we thyroglobulin levels be measured after surgery? Usually these measured after 6-12 weeks, but it is wisely to do it after 3 months. Why? Some tissue produce thyroglobulin, so we must wait 3 months. For example, this is strong recommendation, and measurement of serum thyroglobulin on occasion 12 months after thyroid lobectomy with normal TSH may be helpful to ensure that it is not unexpectedly elevated. However, a specific cutoff value is uncertain. What is the role of ultrasound and other imaging techniques? Ultrasound for the evaluation of the thyroid bed and central and lateral cervical lymph node compartments is preferred method of imaging surveillance for most differentiated cancers. If the serum thyroglobulin levels after surgery is above the excellent response range, and the thyroglobulin antibodies or cervical elevated, the cervical ultrasound and cross-sectional imaging should be performed prior to administering radioiodine therapy. And what is the role of ultrasound here? Here, when we do ultrasound 6 to 12 months following completion of initial therapy, cervical ultrasound to evaluate the thyroid bed and central and lateral cervical lymph node compartments should be performed. Timing and frequency, therefore, are informed by the patient's risk for residual or recurrent disease and response for therapy. Suspicious lymph node or lesions less than 8-10 millimeter is shortest dimension may be followed without FNA unless they grow or threaten vital structures like recurrent laryngeal nerve, trachea, or esophagus, or great vessels. And if the histology diagnosis of recurrent or metastatic differentiated cancer would influence treatment decision or change management, ultrasonography suspicious lymph node or lesions should be assessed, and also with FNA for cytology and measurement of thyroglobulin in needle washout fluid. Here, some patients with thyroglobulin levels or thyroglobulin antibodies rising levels, the total thyroidectomia for DTC and the cervical ultrasound demonstrate the additional cross-sectional imagings to evaluate common metastasis sites, for example, in lungs or bones. They must be done. And also here, what is the role of ultrasound and other imaging techniques after primary resection when thyroglobulin levels or thyroglobulin antibodies levels rise following thyroidectomia for oncocytic thyroid carcinoma or poorly differentiated carcinoma, and cervical ultrasound demonstrate no structural disease or showing only minimal tumor burden. 18 FDG fluid glucose PET scan may be considered. And here, very important scheme to know that what is the response after initial therapy based on type of intervention. There is 4 types of response. Excellent response when non-estimated thyroglobulins less than 0.2 or estimated thyroglobulins less 1 and negative imaging. This is after total thyroidectomia or neck dissection with radioiodine ablation or therapy. Okay, and if it is only post total thyroidectomia without radioiodine ablation, the excellent response is non-estimated thyroglobulin less than 2.5. But here in intermediate and biochemical incomplete response, intermediate response when the non-specific findings on imaging studies or non-estimated thyroglobulins between 0.2 up to 1 or estimated thyroglobulin 1 to 10 or stable declining thyroglobulin antibodies levels. This is intermittent response for patients with total thyroidectomia with RIA ablation, but in patients without RIA ablation, the non-estimated thyroglobulins between 2.5 up to 5 or stable and declining thyroglobulin antibodies levels, and biochemically incomplete if the non-estimated thyroglobulin more than 1 and stimulated thyroglobulin more than 10 or increasing thyroglobulin antibodies or negative imagings for patients with total thyroidectomia or neck dissection with radioiodine therapy. And also here for patients who didn't do radioiodine ablation, non-estimated thyroglobulin more than 5 or increased thyroglobulin antibody levels or negative imagings, and structural incomplete when there is a structural evidence of disease and with suspicious imaging or biopsy proving local or distant metastasis. This is in post-total thyroidectomia and neck dissection with radioiodine ablation. This is the TSH goal after every response. So what is the role of the radioiodine therapy after thyroidectomia in the primary management of DTC? Remnant ablation is not recommended routinely after total thyroidectomia for patients with low risk DTC. This is a strong recommendation. And radioiodine therapy, adjuvant therapy, may be considered after total thyroidectomia in patients with low, intermediate, and intermediate high risk of recurrent DTC. Also, radioiodine therapy, adjuvant therapy is recommended routinely after total thyroidectomy for patients with high-risk DTC. Strong recommendation. In patients with an initial diagnosis of DTC with distant metastasis, or radioiodine therapy is recommended routinely after total thyroidectomy. This is strong recommendation. Here is when we recommend radioiodine therapy for intermediate low and intermediate high. Sometimes it's considered this is the dose, and also we definitely use with in risk in high grade category and distant metastasis. So that's only the dose is different. And should radioiodine be administered for oncocytic thyroid cancer? We said that many studies, Russian studies, proved that oncocytic thyroid carcinoma related to anaplastic thyroid cancer, and the correlation was approximately 20–30%. So we must to be very cautious in this patient, because the only 10–40% of this this carcinoma are radioiodine therapy. Have radioiodine avidity in 10–40%, and so radioiodine is not administered empirically. Evaluation of iodine avidity with a diagnostic whole body scan may be considered. And in patients with DTC, in whom radioiodine therapy, remnant ablation, or adjuvant therapy is planned, preparation with recombinant TSH stimulation is preferred over thyroid hormone withdrawal. This is strong recommendation. Also, how should patient be prepared for radioiodine therapy? We with around LT4 for 4 weeks. FT4 is withdrawn for more than 4 weeks. Substitution of L4 with leutheranine LT3 in initial weeks should be considered. And also serum TSH should be measured prior to the radioisotope administration to evaluate the degree of TSH elevation. And the goal is that TSH is more than 30 should be employed in preparation for radioiodine therapy or diagnostic testing. In patients with now and distant metastasis, either LT4 withdrawal or recombinant TSH can be used for preparation. Should allow iodine diet be prescribed prior to radioiodine administration? Low iodine diet for approximately 1–2 weeks should be used in patients for undergoing radioiodine therapy, remnant ablation, or treatment. And also, low iodine diet generally means the level less than 50 microgram per day. Here, when and how should diagnostic radioiodine whole body scan be performed? Here, post-operative diagnostic 123 or low dose 131 whole body scan may be considered for patients undergoing radiotherapy prior to their therapeutic ablative or adjuvant or treatment administration to help guide treatment planning. Post-operative diagnostic post-therapy imaging generally up to 10 days after treatment dose administration may be identify size of disease even among patients with negative thyroglobulin measurements. That's why we should post-therapy will PET scan will be performed. And should single photon emission computed tomography be performed with whole body scan? Single photon emission computed tomography with computed tomography, SPECT CT, may be performed when available with the diagnostic or post-treatment whole body scan. What other testing should patient receiving radioiodine therapy undergo? CBC and assessment of renal function. Adjuvant external beam radiation for patients with DTC with high risk features for local regional disease progression, such as aggressive histological subtypes, gross extrathyroidal extension or positive emergence, and visceral or soft tissue invasion may be considered in selected cases, especially if the expected disease progression would not be amenable to salvage surgery. EBRT with or without concurrent chemotherapy in patients with DCC with gross residual disease in the postoperative setting or with locally advanced unresectable disease may be considered in select patients who may benefit from improved local regional control. How long should TSH suppression to below the reference range to be monitored? Long-term TSH suppression is not suggested for patients with low or intermediate risk disease who have no evidence of biochemical or structural recurrence, but risks versus benefits of TSH suppression and TSH goals should be re-evaluated over time. What is the role of serum thyroglobulin measurement in the follow-up of DTC? Serum thyroglobulin should be measured by an assay that is calibrated against the PCR 457 standard. Thyroglobulin antibodies should be quantitatively assessed with every measurement of serum thyroglobulin, and measurement of thyroglobulin during initial follow-up while receiving thyroxine therapy should be undertaken every 6-12 months. More frequent serum thyroglobulin measurement may be appropriate for intermediate high or high risk patients, and sometimes of thyroglobulin on measurement of serum thyroglobulin on thyroid hormone in patients after lobectomy during initial follow-up is not recommended routinely. This is conditional recommendation. Can monitoring be de-escalated or discontinued in patients with low risk DTC? As we said before, for patients with low risk DTC treated with total thyroidectomy and radioiodine therapy and sustained excellent response 5-8 years after initial therapy, routine ultrasound can be discontinued, and patients can be followed subsequently with biochemical markers alone every 1-2 years. This is a conditional recommendation. And also some of these patients who has excellent response for 15 years don't require continued routine biochemical monitoring for thyroid cancers and should be considered to have achieved a complete remission. For patients with low risk DTC treated with total thyroidectomy alone or sustained excellent response 5-8 years after initial therapy, routine ultrasound can be discontinued, and patients can be followed subsequently with biochemical markers alone every 1-2 years. For patients with low risk DCC treated with lobectomy, if initial ultrasound is negative, subsequent ultrasound should be performed every 1-3 years for 5-8 years after initial therapy. Nodules in the residual lobe should be monitored as per thyroid nodal guidelines. For patients with low DTC treated with lobectomy, if postoperative thyroglobulin is not markedly elevated, additional thyroglobulin testing is not recommended routinely. This is the how to. This is we just discussed before. Here, diagnostic radioiodine whole body scan recommendation. Patients who have undergo lobectomy or total thyroidectomy without radioiodine therapy should not undergo surveillance radioiodine whole body scan. For patients with DTC who are intermediate high risk patients of recurrence, can be evaluated with diagnostic radioiodine whole body scan to evaluate for iodine affected disease if there is a clinical suspicion for recurrence. Whole body scan, if undertaken, can be performed with 123 iodine or low activity 131 iodine. SPECT-CT radioiodine imaging may be performed in additional to planar imaging to anatomically localized the radioiodine uptake and distinguish between likely cancer and non-specific uptake. This is conditional recommendation. 18 FDG PET scan may be performed in patients with DTC at high risk of recurrence with elevated serum thyroglobulin levels, particularly in patients with oncocytic thyroid carcinoma or aggressive histological features, and in patients who have a history of negative radioiodine image, and in some cases maybe 18 FDG PET scan may be also employed with patients with high risk for rapid disease progression and disease mortality, and in evaluation of post-treatment response following systemic or local therapy of invasive disease. Is ongoing risk stratification response to therapy useful in guiding long-term disease surveillance and therapeutic management decision? When used in combination with the initial risk of recurrence, allow the clinician to provide individualized management recommendation while risk estimates evolve over time and should be used to inform timing and type of imaging. Dynamic risk stratification. Here is the low risk and low intermediate and intermediate high and high risk. Sometimes you know, after treatment or treatment, it depends. Sometimes it go for excellent and sometimes it go for intermediate, and sometimes it develops becomically incomplete or structurally incomplete. That's why we must to follow all patients and accordingly taking the chance that now after mutation genetic testing is available, there are many targeted therapy which is very with very good results. For example, lymphadenib and sulfatinib for differentiated cancers, and fenditinib or cabozantinib for MTC, modulated cancers, and dabrafenib and tramtinib for BRAF mutation, and natriuretic mutation with larotrectinib and entrectinib give more than 70, even 80% if we faced patient who is not radioiodine with more radioiodine response. And so the diagnostic is residual or clinically recurrent DTC isolated to the neck, assessment of node lesion size, thyroglobulin antibodies, treatment options and interventions and monitoring, and assessment of response or progression with thyroglobulin antibodies in Megan's. Thank you.